welcome to Stand Up for Doctors. I'm your host, Kim Downey. Thank you very much for joining us. I'd like to welcome Doctors Kayce Morton and Loden Tiffany. Thanks for joining us today, Kayce and Amy.
Thank
Happy to
you.
be here.
Oh, great. I'm glad to have you both. And by way of a brief introduction, Kayce is a pediatrician and hospitalist in Missouri, and her passion is advocacy, especially in spreading trauma awareness and implementing trauma-informed care. And Amy is an obesity medicine physician, also in Missouri, and her passion is preventing heart disease and diabetes in mothers whose pregnancies were complicated by preeclampsia, preterm birth, and or gestational diabetes. And Amy has a TED Talk speaking to that. So I'm glad to have you both on. And today we'll be talking about the work each of you are doing and how it supports patients and your colleagues. So as we get started, I always ask what you'd most like our audience to know about you. And you can include hobbies if you want, anything you want us to know. Amy, would you like to go first?
Sure. So I think probably the fun fact about me is that I have 5-year-old identical twins and they have way too much energy. So I am constantly trying to stay up and hip and be the cool mom and usually failing. So if any of you out there feeling like that, welcome to the club.
Well, that's fantastic. Yeah, congratulations. And that's a lot of work. My kids are now 27 and 28. So those days are past, but I feel your pain. And Kayce, what would you like us to know about you?
So I'm just born and raised in Missouri here. And then I have a 19-year-old and a 16-year-old. Been with my husband since high school. And recently my daughter went to Arizona State University. So I'm now moving and doing some work in Arizona as a weekendist. So living in Missouri and Arizona, it's been kind of fun.
Wow, well, that's awesome. Yeah, that'll be great to have a second place to go when when you're not happy with the weather in one place, you can go someplace else.
Yes.
Well, that's fantastic. So Amy, would you like to get started by sharing a little about your TED Talk and what you're passionate about?
Sure. So I became aware of preeclampsia, gestational diabetes, just like every other doctor. I learned about it in medical school, really have the impression that you have a pregnancy, the complication occurs, the pregnancy goes away, and voila, you're back to normal. And I'm very passionate about making sure that not just mothers, but doctors understand that's actually not true. The underlying problems that cause those were just unmasked during the pregnancy, but they've been there. They're not going away and they're still there. And it's my belief, and what I'm passionate about is spreading this message to other mothers and other healthcare experts that we can do more and we can do more now, because we know that if we intervene earlier, we can stop heart disease and diabetes from happening much different in a much different manner, which means that not only is mom's health getting better, but her kids' health are getting better. I learned this, unfortunately, the hard way, going through it as a patient in our healthcare system. And I actually have 4 kids, and all 3 of my pregnancies were complicated by different things. And I'm a lean person and physically active. I don't fit the prototype of having these complications, yet they happened. So if I had known now what I did then, I would have done things differently. And I think that's true of most people in our country. I don't think most people are intentionally letting themselves become sick with chronic diseases. I think for lack of education, our people are suffering. And I think that if we can be more invested in early prevention and early reversal of underlying causes, treating those upstream problems and the root sources of chronic disease, we're going to have a much better long-term outcome, save money, save lives, have better quality of life and health outcomes for our population across borders, across states, and throughout the whole country. So that's where I'm coming from and what I'm hoping to achieve.
Well, thank you very much for sharing that. And I would agree with you is that you generally, when you hear someone had preeclampsia or pregestational diabetes, you do think once the baby comes out, everything is fine, and not realizing that that was just a sign or symptom of underlying. So that's important. Thank you for sharing that, because even today on this podcast, I'm sure people are going to learn that didn't know that. And awareness is the first step, right?
100%.
Yeah, thank you. And then Kayce, is there anything that you'd like to share speaking to that?
Yeah, so I mean, with trauma-informed care, I think they kind of correlate. And I think it's funny you say that. We just had actually a discussion today about kids and moms coming out and thinking that breastfeeding is like automatically the way it works. Like you have a baby and they hop on and the milk's there, and that's not how it works. And we really do a bad job in our culture of preparing parents on what is to come. We like to just kind of gloss over it and be like, okay, it's going to work out this way and you'll be fine. And it all goes into place like it should. And so when it doesn't, you lose that bonding time with your baby because you're like, you feel like a failure instead of, knowing that that's the way things are supposed to work. So I think that I agree with everything she says with that. And as a pediatrician, our tendency is to prevent it, like we want to teach parents how to parent their children, learn how to, treat them and help them become healthy and learn those healthy choices so that they can not have those chronic diseases and issues.
Yeah, well, that's fantastic that your missions are definitely related. And Amy, would you like to speak to anything Kayce just said?
I was just thinking, it was a beautiful way you explained it, Kayce. And I think, I think there is trauma in having a child who maybe the first time mom, maybe it's your third pregnancy, it doesn't really matter. But when there's that disconnect, it's painful. It's not the presentation we were taught. And being vulnerable, I'll share my own experience again. Like my first child, I struggled to breastfeed. And in fact, it was such a traumatic experience that my second child, I decided I'm just not going to bother. Like, we know that breast is best, but formula is not poison most of the time, but it is really difficult. And had it not been for a nurse who bent over backwards and went out of her way to convince me just to try one time, I'd written the whole thing off. And so if I'm doing that with all the education and resources as a healthcare person, right? Like how much more difficult must it be for someone who doesn't have access to that? And how much more guilt, feeling of failure and feeling that they're not being a good parent or person who's in charge of their care of the child. I mean, it's a very important topic. So I'm thrilled to hear you're doing that work.
Yeah.
Yeah, well, thanks for sharing that, Amy. And how did you get involved, Kayce, with trauma-informed care?
Yeah. So, I was watching a TED Talk, talking about TED Talks, Nadine Burke-Harris, about trauma-informed care. And it was just basically the ACEs, or adverse childhood experiences primer. And when I listened to it, I mean, it literally changed my whole perspective on what was going on. Like when we can know what childhood trauma is and what ACEs are and how they actually connect to long-term health outcomes and how it affects them in the future, like your perspective on when you look at these patients is just so different. And for me, I personally have a high ACE score. And so, like a lot of times we react, we are triggered by the trauma that we've experienced, but we don't even realize it. And it was just like this aha moment of why didn't I learn that in medical school? Like, how did I not know this and be a pediatrician and see these patients and be like, I can't believe this, because it affects me too, because I'm going to respond with my trauma and they're responding with their trauma. And it was just insane to me. So I just did a deep dive and started learning more about what it was and became involved with different groups and started a pilot at our hospital with our pediatric offices on how can we get the awareness out there, because it is true. Awareness is the first step, right? Like if you don't know that it exists and that it affects us and that it affects our patients, then how are we able to do anything about it?
Yeah, go ahead, Amy.
I just think that we can't stress that enough, because I truly don't believe people intentionally have habits and build lifestyles that are damaging. They don't wake up one morning as a 5-year-old and say, gee, I want to be the adult who has heart failure at 25, right? Nobody does that. And the truth is that most of us are trying really hard to do the right thing, and we've been taught the wrong thing. And I'll give you an example. I do within obesity medicine, I do quite a bit with metabolic wellness and metabolic health. If you look at what the guidelines are for Americans to eat, whole grains, lean meats, vegetables, fruits, right? That's true if you're healthy, but not if you're metabolically unwell. And so if you're trying to lose weight, the last thing you should be doing is eating a whole bunch of whole grains and dairy. It doesn't mean that you can never have them, but it does undermine the effort you're making. So then you've got all these people who are doing their very best, and of course they're frustrated. Why wouldn't they be? And yet nothing has gone wrong. The body is doing exactly what it is supposed to do with these types of food nutrients we're giving it. And it goes back to that same example of failure, and that causes trauma. We cause a healthcare trauma to our patients because we're criticizing and we're labeling them as not adherent or not compliant. And the truth is they're doing the very best they can, just like all of us. They just have different resources and they're at a different place in their journey. And so you complicate that in layers, right? You have social economic status differences, you have cultural differences, religious differences that all go into that. Even myself as an adult, when my parents come to town, I have to ask myself, okay, am I going to eat the way I want to eat, or am I going to eat the way I was raised to eat, right? Being very intentional in those things. And to be clear, there's nothing wrong with what they do, but it's just different from what I need. And being able to say that and articulate that can be very uncomfortable. So for someone who, again, who's very direct, if it's uncomfortable for me, how much more for the person who doesn't want to have that confrontation and just wants to have a happy family life and have the good memories. And so I think we can do so much better, and there's so much further we can go, but we have to acknowledge these things and have these conversations. So I appreciate that you're doing that and giving us this opportunity.
Yeah, I was gonna say, I think it's quite a gift that, with that we're on together and how you're complementing each other, right? And that, Amy, you more come from it, from focusing on like the mothers and what you could do, right, to support them, and from that perspective.
Yeah.
And then Kayce being the pediatrician, right, and working from that perspective and understanding where like trauma plays in, or even if it's the obesity factors, it's like what the parents are choosing to feed their kids or through lack of knowledge.
Yeah.
That it's all parent child, and then as healthcare providers, sometimes like you're saying, we get frustrated, right, if they don't follow through, but we have to understand where they're coming from or where their trauma could come into play, and it affects the healthcare professionals as well. What would you like to say, Kayce?
Yeah, I was going to say, that's one thing I think I always say to my residents and my students is, when they look at a patient, it's really easy to judge, right? And to be like, judgy about looking at a mom that's on her phone and not talking to her kid and be like, well, she wouldn't even pay attention to her kid in the room. And I have to say, well, maybe that mom doesn't know how to interact with their child. What has that mom been brought up in? So just like you stated about the foods, like were you going to eat what you were raised on, or are you going to eat what you think is healthy or know is healthy? And a lot of these parents haven't been parented, and so we're seeing that cycle of them not understanding and knowing and having what is normal, because we know normal is where the magic happens, but if they've never seen normal, how can they make that happen? So as a provider, I try to tell our residents and students, hey, come from the aspect is these people didn't come in here and say, have a baby and be like, I'm going to be a horrible parent. That is what I want. They are like, no, I want to be a good parent, but I don't know how. So our job is to help them be a parent and to support them and give them positive reinforcement versus the negative.
Yeah, it's interesting. I mean, how do you define a good parent, right? Like, I suspect that's different too across generations and cultures and whatnot. So being very explicit about what standards are, how are we defining things makes a big difference. Just even in our personal lives, right? Like, what is a good diet? What is exercise? How do we define these things? Because words matter, definitions matter. And if we are all using the same language, we can get a lot further together.
That's great. So I just shared an episode yesterday with Dr. Sapna Shahak and Jackie Clement, and we unpacked, because Sapna has a podcast, The Worthy Physician, and we talked about what is a worthy physician, what is a good doctor, right? So here we can be talking about, what is a good parent, and what does that mean to you, Amy?
So for me, because my kids are 11 and younger, for me, it means being able to show up. And in fact, I left a very prestigious job to be more involved with my kids. And one of the things that it was a catalyst for me, but at the time my daughter was 7, she's my oldest, and I was doing charts all night, every single night, 2 to 3 hours after dinner. Weekends was doing charts. I mean, I lived on my computer when I wasn't at work, and I thought I was doing a great job because I was like, doing dinner with the family. But it occurred to me that that was my perception of it, right? That wasn't my child's perception of it. And at 7, she sees me working one night and her birthday's coming up and she goes, "Oh, Mom, are you getting, on Amazon to buy me birthday gifts? Can I help you?" Right? The sweetest thing a kid can want, right? That's the magic of childhood. And I kind of was irritated. I was like, "No, honey, I'm doing charts." And she just stopped and she looked at me and she had big tears in her beautiful blue eyes. And she's like, "Why do you love your job more than me?" And I put her to bed. Of course, I put the computer, like I'm hugging her, I'm trying to show her, but the damage is already done. Right. And so that for me was a very big change in what I defined as being a good parent and a good doctor. And told my husband that night, "Listen, this isn't working. Either I find a new job or I retire." And he said, "There's no way you're retiring." So I was like, "Okay, well, I'm going to find a new job." So I did. And it's been painful. It's been difficult, but I opened my own clinic 4 years ago. And now I'm able to do what I define being a good parent as, which is defining my hours in a way. And I tell all my patients, "Listen, I work school hours. If that's a problem for you, I get it. I'm not the right doctor for you." And setting those expectations in my physician hat is what's allowed me to show up better in my mom hat.
Wow. Well, thank you for sharing that. And right, setting boundaries is so important. And that was like what they call like a mic drop moment for you.
Yeah.
But that was great that you were able to pivot, and doctors sharing their stories, like some doctors, I think, sometimes from what we hear, don't see options. They're like, "Well, it's the system. The system is a problem. There's nothing I can do about it." But you felt some agency yourself, and are like, "I have to make things different for my life and for my family." And you took the steps that you needed to do.
Right.
So that's fantastic. What would you like to say, Kayce?
I think that as I was talking about kind of what you see as a child and your parenting skills and everything else, that for me, being a good parent was being different than the parent I came from. I did have a supportive family member, and I definitely had the love and support I needed. And that's why I think I was able to thrive and be resilient. So my goals were to just have the interactions with my child and to be consistent and steady. And sometimes when we look at parenting, that's all they need, to know that you're there for them, that you can be there. And so when I did choose my job and chose pediatric hospital medicine, it was because of that flexibility, because it wasn't, a set 8 to 5 schedule. I had the ability to leave work if I needed to. I was that homeroom mom in the classroom. I was there for the different middle of the day assemblies, and I worked with a group that the culture supported that. So I feel very fortunate, but I will say that I did all of that. And then when you don't make something, you're missed, right? Yeah, my daughter would be like, "You're not coming?" And I'm like, "One thing," so it gets to a point where, I think it's, they see that, but at the same point, I'm like, "No, it's important for me to work. I still enjoy my job. This is what I want to do, but I also want to be there for you. And I can do both of those things. Just sometimes one takes precedent over the other." And so I think for me, just that consistency and the normal and just being there, and they know that regardless of whether I show up to an event, that they can still count on me.
Yeah, I love the way you say that. And I know there's some people talk about like work-life balance, but then other people would say, well, it's life balance.
Yes.
Right?
Like integration.
Yeah, exactly. Well, I want to make sure, Amy, that we share anything else that you want to share, speaking to what you're passionate about in the heart disease, diabetes, and mothers. Are there any messages that you want to get out to the audience, things that people should be looking out for?
I think if you've had any of those pregnancy complications, one of the biggest disappointing things in our system is the transition between OB care and primary care for moms. It's not uncommon that women in their 20s, 30s, even 40s will use their OB as their primary care provider. And there's nothing wrong with the care that's provided. Please don't hear what I'm not saying, okay? But for those moms, they need something that's beyond the general OBGYN's scope of practice. And I don't know that I've met any GYNs who would fight me on saying, "I would love to manage cholesterol," right? Or "I would love to be in charge of diabetes," not for the non-pregnant mom. And so I think it's very fair, and Kayce, jump in if you think I'm misrepresenting, but I don't think most OBs want to do that. And what's really unfortunate is most moms don't realize that they're not getting the care they need. So they might make their sick leave up, they might make it, or most likely they won't, is what the studies actually show. They certainly are unlikely to see a primary care doctor about those pregnancy complications. And what's even worse is most primary care doctors don't even know if this is a problem. Because like I said, we're not taught in medical school that we need to be following up on this. And yet for the past 10 years, American Heart Association has said these are risk factors for diabetes. We know that within 5 years of gestational diabetes, half those moms are going to have type 2 diabetes, but most moms don't even know that. So they need more aggressive screening. They need to be seeing somebody who's plugged into that information. And the reality is there's just not a lot of people. So they may have to advocate for themselves and go to their doctors and say, hey, look, I know I'm at higher risk, so I know I need more screening. The other thing, and this is something that I am going to very hopefully respectfully and gently tell my colleagues that we need to be doing a better job on, is we're not diagnosing insulin resistance at all in most people. We're acknowledging that insulin resistance causes prediabetes and eventually diabetes. We're acknowledging that it has a role in gestational diabetes, but we're not actually doing anything with it. And if you look at the numbers for hemoglobin A1C, assuming hemoglobin is normal, the A1C number we're quoting people as normal is 5.7 is prediabetes. So 5.6 therefore is normal, but that's nonsense. You don't just go from 5.6 to 5.7. There's a whole transition point from 5.5% to 5.6% that's insulin resistance, and that's reversible. So we ought to be being much more aggressive, in my opinion, in helping these individuals. We also know insulin resistance is linked to high blood pressure. So in a decade, are we going to find out that the whole problem with all of these diseases was the same problem that we should have been treating? I don't know. But I'm going to put my stake in the ground here and say that we should be doing a lot more for these individuals with insulin resistance and stop telling them their A1C is normal. It's not, and we need to be addressing that more aggressively so that we reverse it and prevent these diseases as adults.
Well, thank you so much for sharing that. Again, like we said earlier, raising awareness is the first step, because most doctors want to do a good job too, right? But like you said, you didn't learn a lot of these things in medical school. So again,
Right.
just raising awareness, and then when we know better, we can do better, right? Any of us, no
Mhm.
matter our profession. So thank you for sharing that. And Kayce, if there's anything you'd like to speak to follow up what Amy said, and then also I'd like you to share anything else you want to tell us about your, work with trauma-informed care.
Yeah. No, I just agree. I think that completely we have to be aware. I think menopause care is another area that we see a lot of ignorance in, and just kind of not ignoring it really, because we don't want to deal with it, or we haven't been trained to do things. And I think that's the same thing with trauma-informed care going into what I do. I've been working with the American Academy of Pediatrics, and we've done an echo where, there's sessions that you kind of learn about each step, because it is a lot, even for awareness, to know how trauma-informed care is done, to know what childhood trauma is, what ACEs are, how they're interrelated, and how it affects us as hospital caregivers, or our staff, or our patients. So, learning that, like you said, awareness, but there's a process where you go from awareness to implementation to, knowledgeable to informed. I mean, it's not like you get here and then all of a sudden you're at the end. It is a, 5 to 6 step process. We utilize the Missouri trauma-informed care guidelines, like through the state, that kind of show you. And so if you can take it into your facilities and use them. Currently in our hospital, we work with a champion group. And so each champion group can kind of take to their areas, what is that awareness and what does it look like, starting with our new physicians and our residents. And, once you're aware, it's kind of like that thing, you can't go back. And when you're you can kind of be like, okay, at this point, I know that I have to do better. I have to look with that trauma lens. And when you're going into an office with workers, we know how staff retention is right now, right? It's difficult. They're stressed. They can't do things. They're quitting, they're burning out. This improves that. It can increase the emotional well-being, not only of us, but of our colleagues and of our patients. And integrating that can heal the trauma that we've experienced, and just making it aware of what's happening. I think we see this in schools too. Trauma-informed schools is a big deal right now. We have kids that are going in there that are acting out and not able to learn because they're experiencing things that they don't know, and nobody's recognizing that this isn't just behavior, this is actual trauma. So the more that we can get that word out there, then the better that we'll see our our ability to learn from each other and help each other, and that's where we talk about that empowerment. You know what your triggers are. What do you do? How can we cope with those triggers? And just because you get them again doesn't mean you're not going to go back and improve and cope and learn how to heal.
Yeah, that's so important. So, what messages would you like to share, with patients, and or with your colleagues in regards to that?
I think just being proactive and learning first and foremost what is childhood trauma and how you can address it. Asking the question, how are you, or what happened to you, versus what's wrong with you. That's the biggest key. Being an active listener and going in with positive reinforcement on what they're doing right. So instead of saying you're not doing that right, you shouldn't be doing this, but great job, you're going through a stressful time right now. That you did a great job. What can I help you with? How can I make that better for you? How can we get you to where you need to be? So I think, us being able to do that, and even with our own staff, like understanding that they're coming from a place that maybe something's going on in their lives, and like, how can we address that and make it a safe culture for them to come to work every day?
Yeah, that's great. And words matter. I like that you brought that to our attention. And also, we have a largely physician audience, but not everyone is necessarily has a medical background. So if you could just take a moment to share the acronym for ACEs for those who might not
Yeah.
know.
Adverse childhood experiences. So initially, the Kaiser study actually was a study done after an obesity study, when they found out that a lot of their obesity had gone through bariatric surgery and had not been compliant. And then they kind of figured out that there was a lot of sexual abuse that was noted in there. So it addresses those different 10 initial, and then there's been studies that have gone, but that's neglect, physical abuse, mental abuse, sexual abuse, mental disorders in the home, substance abuse in the home, parents or kids of incarcerated parents. So those are kind of the main 10 things that they assessed in that first initial study that kind of showed that these kids had these huge amounts, once they were greater than 4 ACE scores above, increases in chronic healthcare outcomes.
Yeah, well, thank you. I didn't know I wasn't aware of the full history behind it. So thank you for sharing that.
Yeah.
And as we start to wind down, Amy, would you like to share any top tips for your colleagues, from seasoned physicians to med students, or even those considering med school?
Sure. I think Kayce said it beautifully, like what happened to you, right? And we often go into these exam rooms prejudging someone based on a vital sign that was collected for us. And I think it's really important to truly understand, which only means that you get there by asking questions. You don't get there by giving diagnoses and prescribing medications. Those may be appropriate steps, but asking questions and understanding, I think, is critical. And regardless of where someone is in their medical school and medical education journey, I think we can always follow the science. And that is why I've taken some dramatically different turns in what I was taught in medical school, where, I trained at Cornell. It was a fantastic experience, but I didn't learn these things, right? These were things I learned outside, and I had to do it by looking at the science and continually listening to my patients. And I think that's what all of us are called to do in our work, is listen to our patients and look at the science and admit that sometimes we don't know. Sometimes things change. Sometimes we're going to put stakes in the ground that are wrong. And if we're not humble enough to say, hey, this is not right, we're not going to make progress as a culture or as a country.
Absolutely, 100% to all that. And I went to Ithaca College, so we were in the same
fun.
college
Yeah.
town. So I
Yeah.
love that. Kayce, what would you like to share?
I would just like to make sure that if we don't have early intervention and support, that we won't see improvements in long-term health, so addressing the childhood traumas that have happened, making trauma-informed care a part of your practice, making sure the culture of your practice is safe for everybody that is there, and assessing those needs. And a lot of times people like to say, well, I'm going to ask about these things, but I don't have the resources to give them, so I don't want to ask about it. I've heard it with postpartum depression screening in pediatrics as well, where we're asking the question, but then I don't have anybody to refer them to. So not knowing's better, and that's not the answer. Knowing is better, and sometimes the act of them just giving you the information and being able to talk about what's happened to them is enough initially. But that means then you have to make that next step to say, what can we do to help you? And maybe I don't have the resources, but know somebody's working for you. So as long as you have somebody working for you, you're always going to have that, feel that you have that support you need to continue to try to be the best parent and the best person that you can be.
Yeah, thanks. That's so true. Yeah, absolutely. And I was wondering if do you have any suggestions for patients who wish to support their doctors? Amy?
Yeah, I think it's tricky because a lot of doctors have been trained to think that we know best. And we'd like to say that we don't and that we're going to listen to our patients, but that's not what I observe. It's not who I was. It's not what I was taught. And I don't want to, I don't want you to hear again what I'm not saying. I don't think that physicians are terrible people and that we're all wrong, right? Like, but we are humans. And that's a really important connecting piece. And I think that patients can come at this in a way that's empowering to them and allows them to communicate with their doctors. And they have to understand that many doctors are in a situation where they might have 12 minutes with you. And so asking them to review a literature or coming in with all the evidence and saying, this is what I want to do is not going to be productive. It's probably going to take multiple visits to have that full conversation. And I wish it wasn't that way, but that's the reality of the system that most of the physicians are working in. So trying to work with the system, as broken as it is helpful, even from a patient perspective, versus coming in trying to fight, because it's not going to work. Unfortunately, it's just the doctors, the nurse practitioners, all of us, we're just going to be like, no, I got to go, bye. And that's a trauma in itself, right?
For sure. So patients should be as informed as they can and bring the information in their chart history to help their doctors out, right? So they don't have to weed through 40 years.
Without, yes, but without sending them like an hour's worth of data
Oh, right.
and
That's
fix my
yeah.
chart, right? Like
Yeah.
that's traumatic also.
Right. That's
So,
true.
like, I would say if I was going to have the perfect situation, it's somebody saying, hey, this is an article I saw. I'd love to talk about it at our appointment next week. Fine, I'll look at it. But that's the only thing we're going to talk about in my 12-minute appointment with you, right?
Right.
That's probably a better way to put it.
Okay, that sounds great. Kayce, do you have any suggestions for patients who wish to support their doctors?
Yeah, I just think being open to communication, like a lot of people come in with a idea of what they want and what they need and aren't always open to other ideas. So, opening about that and being able to advocate for your needs in a way that is supportive and not, judgmental or angry. So, just having that and then making sure that they have questions so that we can answer those. So having questions helps us clarify what are their real priorities and prioritizing those needs so that we can help them. Like she said, we have 12 minutes a lot of times or not very much time. And so, we both have to have patience and know that sometimes one appointment's not going to be enough. Just like she stated, we might have to meet again and discuss these things, and we might have homework, that we need to do, or things that we need to look into as well, or they need to look into as well before we meet again, and make sure that we're coming knowing that this is a shared partnership for health.
We're on the
Right.
same team.
Exactly. Right. Absolutely. Right. For sure. So Amy, how can our listeners get in touch with you?
Sure. Just go to my website, vitalitymwc.org. It's Vitality Medical and Wellness Consulting. I'm also on multiple social media channels. Feel free to follow there. I try to provide short little answers to questions that we get frequently that anyone can check in on.
Okay. Excellent. Thanks. And Kayce, how can our listeners get in touch with you?
Yeah, you can find me on my email at Kayce, Kayce.Morton, Morton at coxhealth.com, COXHEALTH. And then I'm also on the Greene County Medical Society Foundation website and the Missouri AAP website.
Okay, great. And thank you both for being my guests. I loved our conversation and even the synergy and where areas overlap, right? Because on the surface, a trauma-informed and care pediatrician and then, obesity medicine physician, right? You wouldn't necessarily see, but when we see how it's all interconnected, mother, child, physician, and all of us coming with our own everything, right?
Yeah.
Up as ourselves and how interrelated it is. So I think this was a beautiful, important conversation. So thanks again for everything that you shared.
I really
Thanks for
enjoyed
letting
it.
us.
Thank you.
Yeah. Thanks for the opportunity to share the message.
Okay, terrific. So, in closing, to move the needle in healthcare, we all need to raise our voices and we all need to care about each other. We already know that doctors need to care about patients. Patients need to care about doctors too. So stand up, doctors, and let's stand up for doctors.